Hello, everyone. I'd like to thank this invitation and also the nice introduction. Today's topic is on the role and the potential of fine needle aspiration cytology in pediatrics. I was very pleased when I was invited to do this webinar in this particular topic that is quite dear to me. For more than 30 years that I've been working in this field as a cytologist and also as a pathologist. So it is with a great pleasure that I'm now able to share my personal experience with you. We will cover several issues summarized in this slide through a number of quizzes. Are pediatric tumors different from the adults? What is the spectrum of the most frequent pediatric tumors diagnosed with fine needle? Is performing fine needle on children the same as it is on adults? And also we will focus ourselves in specific diagnosis of pediatric tumors, non-central nervous system, located in the head and neck, in the kidney. We will also speak about small round cell tumors, germ cell tumors, and finally, lymphomas. Pediatric tumors are different and from the adults, not only on the basis of the clinical presentation and prognosis, but also morphology and the molecular point of view. In general, and contrary to what happens in the adult population, a child diagnosed with a highly aggressive malignancy is not necessarily a malnourished, pale, or unhealthy-looking child. In most cases, the tumor is discovered in an apparently healthy child, followed by the pediatrician after a trauma or other type of accident that causes internal bleeding and consequently sudden pain and enlargement of the tumor. Curiously also, some very aggressive adult-type tumors like carcinomas deal with good prognosis in children. Morphologically, children are more prone to have undifferentiated tumors like blastomas instead of well-differentiated tumors like carcinomas that are very rare in this age group. And from the molecular point of view, the molecular mechanisms of pediatric cancer are equally diverse. The role of exogenous factors that is important in the adult cancerization is much less important here, as exposure time is reduced and the main role is directed by endogenous factors as well as familiar syndromes. Also, with the exceptions, pediatric cancer exhibits a lower mutational burden and a relatively high prevalence of specific structural variations like gene fusions and chromosomal rearrangements that fortunately for us exhibit a high specificity and association to histologic tumor subtypes. And that will help us, as we are going to see further on this presentation, in the diagnosis. When considering a child with a lump, several factors should be considered. As a pathologist, we are to be aware of it. The type of neoplasia is related to age and topography, so clinical detailed information is essential in a first approach to the cytological diagnosis. As a note, some locations are related to specific neoplasia. This is the case of primarily mediastinal large B-cell lymphoma. Also considering mediastinum, we also know that depending on the mediastinum compartment, some tumors are more frequent than others. For example, neuroectodermal tumors are more frequent in the posterior department and lymphomas instead are more frequent in the anterior mediastinum. Then we have organ-specific tumors like blastomas, hepatoblastoma, nephroblastoma, pleuropulmonary blastoma. Also, sarcomas like congenital fibrosarcoma or synovial sarcoma are more frequently in the limbs. An important information to be taken. Some tumors are congenital or should be considered just in the first months of age. This is the case of congenital fibrosarcoma, mesoblastic nephroma, and pleuropulmonary blastoma, retinoblastoma, and even hepatoblastoma. Others, however, occur more frequently in childhood, like rhabdoid tumor and cell sarcoma, clear cell sarcoma of the kidney, and others occur late in childhood and adolescence. This is the kind of carcinomas, and these kind of tumors resemble more their adult counterpart, like carcinomas and some kind of sarcomas. The main aim of fine needle aspiration in pediatrics is quickness and an assertive diagnosis. A lump or a mass in a child is always a cause of concern, not only for the parents, but also for the clinicians and consequently for us pathologists. In a first approach to diagnosis, the main objective is to exclude malignancy and to proceed as quick as possible to an appropriate therapy, avoiding unnecessary surgeries, long hospitalizations, and lengthening healing times. Fine needle aspiration, therefore, plays an extremely important role in reducing the anxiety of the parents and of the clinicians. Is performing fine needle in children and in adults the same? Technically, it is. But we know that children don't like needles, and it's not easy to get their collaboration performing this technique. In practice, we should bear in mind that we only be able to perform one puncture. It will be very difficult for a child to let us repeat the procedure. We should be calm. We should forget about all the slides which are waiting for us in our work table and calmly explain the procedure to the child if she's old enough to understand without emphasizing them and reassuring them. Empathy is very important to perform symptom optimization. If you have a child that is afraid of what we are going to do, we'll have bloody smears and poor material for further studies. And if you create empathy, you will be astonished how collaborative they can be. And so you will get nice smears and enough material for other techniques. Nowadays, a purely microscopic diagnostic approach is currently insufficient for a correct clinical and therapeutic management of the patients. In both adults and children, we are currently faced with the need to perform ancillary techniques not only for the accuracy of the morphological diagnosis, but also for prognosis and for decision and target therapies. Therefore, we want cytological material to be in ever greater quantity and quality to perform ancillary techniques that we might be needing, but at the same time, we also want to be less and less invasive. In children, this dilemma takes on a greater proportions, and it is in this environment that fine needle plays an indispensable role in enabling us to do more with less. The cytology diagnosis in reality is a multidisciplinary diagnosis. Prose takes an important role here. A capacity of performing a quick view on our slides and in a lens have an idea of the possible differential diagnosis will help us to decide which complementary techniques we will need and decide how much material we will need and what means of fixation are we going to perform, thus optimizing the sample and managing to do a lot with very little. Let's now move on to the next point. We will now discuss the different diagnoses and the most frequent dodges of fine needle. We will start with the head and neck. Head and neck region is a common site for occurrence of lumps in children. Many types of lesions are to be considered. They can be infective, they can be reactive, cystic, developmental aberrations, and neoplastic. Some cancers can occur almost exclusively in childhood in this location. This is the case of cyeloblastoma in salivary glands or melanotic neuroectodermal tumor of childhood. Other entities more typical of the adults, such as thyroid carcinomas and salivary gland tumors, represents, however, a relatively significant proportions of pediatric malignancies, but are essentially diagnosed in older patients. In the present study, Wadan and al., they analyzed the cytomorphological spectrum of head and neck lesions in the pediatric age group between 13 and 18 years old. They reviewed 238 cases in a 3-year period. Curiously, most cases were fine needle aspiration of lymph nodes, and then the second most frequent topography was thyroid nodules. Curiously also, they also find in all these fine needles only 18% of neoplastic lesions, and from these, only 27% of these 18% were malignant. Thyroid nodules. Thyroid nodules in children are more likely to be malignant. Cystic lesions are also more frequent, and also the risk of malignancy when the cytologic diagnosis of ALS is performed according to the Bethesda system also have a higher risk of malignancy. This is why other indications differ from the adults. So in children, a nodule in thyroid with more than 1 centimeter or less than 1 centimeter, but with suspicious features or clinical risk factors is an indication to do fine needle aspiration cytology. Contrary to what happens in the adults, a diagnosis of ALS is not an indication in children to repeat. Instead, it is an indication to proceed to histology. Salivary gland tumors are rare. In most frequently diagnosed are pleomorphic adenoma and mucoepidermoid carcinoma. Morphologically, they don't differ from the adult counterparts. So we will not take much time in this. Let's now look at some practical examples. This is the case of a 6-year-old boy that has an enlarged lymph node in his neck. Fine needle was performed, and our smear displayed abundant polynuclears, neutrophils, some histiocytes that you can see up, and also squamous. This is a characteristic cytological pattern of a branchial cyst, and this is an easy diagnosis that you can make just with your eyes. Another situation, also very simple for us, and that is very reassuring for the parents, is a newborn that presents with a hard sternocleidomastoid neck lump, and fine needle is performed, and we have a characteristic cytologic pattern of several spindle cells that are dispersed in the background or in aggregates. And also we will find some muscle cells with reactive changes like multinucleation. This is also a characteristic picture, and you don't need ancillary techniques to perform the diagnosis of a fibromatosis coli. This is a benign lesion, and it will solve only clinically, and in most situations there is no need for surgery. Let's move on to another case. This is a more dramatic case with a more aggressive lesion of a 9-year-old boy. An expansive osteolytic lesions about 3 centimeters, center in the right orbit, with bone erosion and a soft tissue component. You could do fine needle to the soft tissue through here if you have your child sedated. However, in this case, there was a lymph node near the parotid. And so we decided to do fine needle first here. And we had this kind of smears that were also rich in some neutrophils and some eosinophiles. And there were dispersed histiocytic cells as well as in aggregates. Here in GIMSA stain, you can see with more detail the presence of some eosinophiles. So this is this kind of cytological pattern should make you think about the diagnosis of a Langerhans histiocytosis, especially in this kind of location involving the bone and in a child. So we performed an immunostain CD1A that was strong positive, and the diagnosis of Langerhans cell histiocytosis was performed. This is a similar story. However, this is a rhabdomyosarcoma. There was also an expansive lesion centered in the ethmoid labyrinth, with involvement of the nasal cavity and the frontal bone and right maxilla. And in this case, the child was sedated and fine needle was performed through here. And in our smells, we could see a small round cell tumor with aggregates, a tigroid background in the Gibbs stains. This is a kind of background that you are going to see further on this presentation. It is very helpful to distinguish rhabdomyosarcomas and other tumors that may have this kind of pattern. This is the case of Ewing sarcoma and some germ cell tumors like seminoma. And so we performed some immunostains in our cell block, and MyoD1 was positive, so the diagnosis of rhabdomyosarcoma was performed. This is one case when you do this kind of diagnosis. It is imperative to perform also molecular tests, specifically NGS, to search for fusions of BAX7 and BAX3 gene that will help you diagnosing alveolar rhabdomyosarcoma, because that kind of therapy is going to be different. Case of a 10-month boy with also several lymph nodes on the neck. We performed fine needle in one of them, and we got this nice picture of a smear with some lymphocytes and a lot of macrophages with emperipoles of small lymphocytes. This is a classical picture of a Rosai-Dorfman disease. You can confirm this with CS100 and CD68 that is generally positive, and CD1A should be negative. Rosai-Dorfman disease, it's a common histiocytic disorder, most frequently presenting as a bilateral cervical lymphadenopathy in children and young adults. The pathogenesis was previously poorly understood, but however, recently there has been evidence of clonality in a subset of cases, raising the possibility of a neoplastic process. Other papers relate this kind of disease with EGG4 related diseases also. Now, let's look at the classical cancer in pediatrics, small round cell tumors. When you think about cancer in children, you have to think about small round cell tumors. You cannot escape. In other words, they are characterized by a monotonous population of single small round blue cells. And also, under this designation are included several neoplasms, such as Ewing, such as Ewing neuroblastoma, desmoplastic round cell tumor, rhabdomyosarcoma, lymphoma, and other blastomas. There are some kind of tumors that, even though they are not considered small round cell tumors, they have a fragile cytoplasm. And so in our smears, we only see, in most situations, naked nuclei, and they can be confounded with small round cell tumors like rhabdoid tumors and clear cell sarcomas. Wilms blastema also is considered a small round cell tumor, and there is a subtype by synovial sarcoma with small round cells that should also be considered in this group of lesions. The approach to the cytological diagnosis of these neoplasms should be systematized. A detailed evaluation of the type of background, cellular arrangement, nuclear and cytoplasmic details should be performed. like the presence of fibrillar background and rosette formation, as well as salt and pepper chromatin, should alert you to a neuroblastoma, for example, or the presence of a thyroid background, tadpole or Recurrent cells, should alert you for a rhabdomyosarcoma. So let's see this in more detail. When considering the type of background, three types of background can happen. The thyroid background, I've told you before, this is common in neoplasia that are very rich in glycogen, lymphoglandular bodies, and fibrillarium background. This is generally occurs in neuroblastomas and ganglion neuroblastomas, and this fibrillary background that you can see here, it's a very fine background, and it is composed of neuropils. Lymphoglandular bodies are common in lymphoma, and thyroid background is common in rhabdomyosarcoma, Ewing sarcoma, and other tumors not of this group, but can also have this kind of background like renal cell carcinoma and seminoma that we will see further on. The type of cell pattern also can be divided in three main types. Single cells, like it occurs in lymphoma, the presence of rosettes, like in neuroblastomas and sometimes in Ewing tumors, and those that I called poorly grouped cells, like in rhabdomyosarcoma, Ewing also, and Wilms blastema. What about the kind of nuclei and chromatin cell characteristics? Salt and pepper, clear chromatin, and fine chromatin are three kinds of characteristics that you can find in this type of tumors. Salt and pepper is a neuroendocrine typical chromatin. It occurs in neuroblastomas and ganglion neuroblastomas, and clear chromatin is very representative of a rhabdoid tumor or clear cell tumor of the kidney. There is a fine chromatin in Wilms blastema, Ewing, and rhabdomyosarcoma. In most instances, immunostains are essential for achieving the diagnosis. However, many of these entities share immunoreactivity for some antibodies, thus hindering our diagnosis. But some antibodies are quite specific. This is the case of GATA3. GATA3 has enormous importance here. Remark here in this table that neuroblastoma is the only small round cell tumor that has GATA3 positive. Not even stasio-neuroblastoma has got it. Myogenin is a muscle marker, so it's specific of rhabdomyosarcoma. And FLY1 and CAPX2 are markers of Ewing sarcoma. So they are going to be helpful in the diagnosis. TLE1 is very helpful in synovial sarcoma because it's very specific. WT1 also shows immunoreaction in Wilms and in desmoplastic intraabdominal tumor. Molecular alterations are also characterizing specific types of malignant small round cell tumors like Ewing, desmoplastic, alveolar rhabdomyosarcomas, I have told you, and in between others. I'd like once again to remind you of the importance of rows in the sample optimization to perform all these techniques. Let's look at a case study. This is a 6-year-old boy. This is a quite recent case in our department. He presented with a huge mass on his left back with destruction of the scapula and the involvement of the soft tissue. Fine needle was performed using ultrasounds. This is the scapula here, and this is the tumor destroying the scapula. And in our spares, there was a small round cell tumor. And here in this GIMSA stain, you can remark some cells are clear and others are darker, very characteristic of a Ewing tumor. So we have performed in our core biopsy that we performed during rows. We have decided to do core biopsy for further studies and more material. And we performed some immunostains, and CD99 showed a wonderful and beautiful positivity of membrane. and FLY1 was also positive. So the diagnosis of Ewing tumor was rendered. Let's now move on to renal tumors. Wilms tumor is probably the most frequent renal tumor in this period of age. And renal tumors constitute about 7% of all childhood tumors. This is a classical cytological pattern of a Wilms tumor. It is composed of three components: mesenchyma that you can see here. You have sheets of immature epithelium that can be in sheets or small ductules, and you have a lot of small round cells here that are blastema. Other tumors that you can find are mesoblastic nephroma. We have talked already when we talked about the age of the patients and its importance. Rhabdoid tumor, clear cell sarcoma tumor of the kidney, metanephric adenoma, and renal cell carcinoma. Fine needle was the usual first approach to a suspected renal cell tumor a few years ago. In specialized departments and also in our department, and with good success. From the morphologic point of view, the cytological diagnosis of pediatric renal tumors is very rewarding and carries a minimal risk for complications. The material obtained is excellent for both cytological diagnosis and for further techniques. In most cases, the diagnosis offers no difficulty. However, there is a controversy that's recent. That was created regarding the role of fine needle in renal tumors. There are at least two main clinical protocols approaching renal pediatric tumors. The one that is most used in Europe by CEOP, by the International Society of Pediatric Oncology. The most recent protocol is called the Umbrella Protocol. It was done in 2016. And the American group protocol, that's National Wilms Tumor Study Group. The CEOP protocol uses preoperative chemotherapy to minimize the risk of tumor rupture and stratification of post-operative chemotherapy based on tumor response to treatment. Upfront nephrectomy is advocated only for children less than 6 months of age, where there is a much higher incidence of tumors that do not require cytotoxic treatment, such is the case of mesoblastic nephroma, a benign tumor, or to cystic lesions also. Consequently, biopsy is contraindicated less than 6 months of age and in cystic lesions, being only indicated as a first approach in the diagnosis of pediatric renal masses in children over 6 years of age or in cases with an atypical presentation. Why 6 years of age? Because from 6 months to 6 years of age, the most common tumor you have in the kidney in this age group is Wilms tumor. The TOG group, the American group, does the contrary. The upfront nephrectomy is advocated to achieve an accurate diagnosis prior to postoperative chemotherapy, as such biopsy also becomes unnecessary. The exception is in rare non-surgical cases. Like previously mentioned, the cytological approach should follow a step-by-step evaluation. Clinical imaging information and the knowledge of the patient's age are crucial to include or exclude some of the differential diagnoses. Mesoblastic nephroma is a congenital tumor present in the first 6 months of life. Wilms tumor is generally diagnosed between 6 months and 6 years, I previously told you. And renal cell carcinoma and metanephric adenoma is generally diagnosed in young adults or in adolescents. Let's now look at the differential diagnosis between renal tumors. Consider Wilms tumor as the most common tumor, and as it is composed of 3 types of cells, mesenchyma, blastema, and epithelium, in several different proportions, it will depend on our cytological pattern. We have a cytological slide with predominant mesenchyma or predominant blastema or predominant epithelial, and this will take us to several differential diagnoses. In the first case, mesoblastic nephroma and clear cell sarcoma should be considered. If blastema is predominant, small round cell tumors should be considered in the differential diagnosis. And if epithelium is predominant, then you should consider as differential diagnosis metanephric adenoma, papillary carcinoma, and even renal normal epithelium. Let's look in more detail. Mesoblastic nephroma represents about 2-3% of pediatric renal tumors. However, under 3 months of age, 70% of the kidney tumors are mesoblastic nephroma. As well as clear cell sarcoma, the cytological pattern resembles Wilms mesenchyma. But immunostains will help us in the differential diagnosis. In the first case, we have a specific translocation that is shared also with infantile fibrosarcoma and will permit us to perform a special immunostain and track that is positive. CD56 is negative, and generally Wilms tumors, it is positive. A clear cell sarcoma is a B-core tumor, so we will have B-core molecular alterations and B-core immunostain positive, and WT1 is in general negative. Considering the epithelia in Wilms tumor, metanephric adenoma is the more frequent renal tumor in children. It is a rare renal tumor, but it is composed of small immature uniform tubules or papilla reproducing morphologically and immunohistochemically immature metanephric tubules, just like in Wilms. Psammoma bodies are more frequent here in metanephric adenoma. And once again, metanephric adenoma is also a BRAF molecular mutation in 90% of the case, so you can do immunostains to locate it. You have a CD57 that is generally positive and intense, and it is not in Wilms tumor. And also, you will have a CK7 and a racemase negative. This will help you distinguishing from papillary renal carcinoma. Considering blastema and small round cell tumors, we have neuroblastoma that can occur inside as primary lesions of the kidney or even at the periphery of the kidney, destroying the adrenal and involving the kidney. So it will be difficult in a fine needle to locate the exact location of your tumor. So once again, SGATA3 is very important. It is positive in this. It is negative in all other small round cell tumors. WT1 is negative in neuroblastoma, and also Ewing tumor. You know already we have a tigroid background not present in blastema, and you will have FLY1 and NCAP-X2 positive, and you can look for specific translocations by molecular techniques. Clear cell sarcoma, rhabdoid tumor, I previously told you, they are not in reality small round cell tumors, but they can look like it in our smears. Sarcoma is characterized by these clear chromatin, some coffee bean nuclei shapes, and rhabdoid tumor has enlarged nucleoli and eccentric cytoplasm, sometimes with an inclusion. This does not happen in Wilms tumor. When you have good preparations, rhabdoid tumor, it will not get difficult to do this diagnosis. Once again, immunostains are helpful. WT1 is negative here. NI1 is also negative in this, and it's positive in all other tumors. Clear cell sarcoma, I told you it's a B-core, so you can do immunostains, you can look for molecular alterations. Let's leave now kidney tumors and move on to germ cell tumors. Germ cell tumors account for about 3% of childhood and adolescent cancer and represents 13.9% of all childhood cancers. However, in adolescents between 15 and 19 years old, this type of cancer can be much more frequent. There is a bimodal distribution peak, one between born and 4 years old, and one between 15 and 20 years of age. These tumors originate, from germ cells, and they represent a very heterogeneous group, covering both benign and malignant tumors of gonadal and extragonadal origin. In 80% of germ cell tumors in the children are extragonadal. They can be in the sacrococcygeal area, in the mediastinum, retroperitoneum, head and neck, and even central nerve system. Only 20% in children occur in the testes or in the ovaries. Also, there are some differences according to age. In prepubertal children, teratomaniac sac tumors are more frequent, and in postpubertal children, malignant germ cell tumors are more frequent. Also, gonadal and mediastinal sites represent about 15% of the situations. This is the case of a male, 70-year-old, so he is a post-adolescent male, and he has a cervical lymph node that is enlarged. In his history, past history, there was the information of the remotion of a testicle 2 years before. So this is the sample we have obtained. There is a mixture of a background rich in lymphocytes and plasmocytes. There are some spindle epithelioid cells, and there is these large and atypical cells with huge nucleoli and large cytoplasm. In another slide, you can see in more detail that these cells are pleomorphic and with atypical nuclei. In cancer stains, you get this type of background that I already mentioned you, and you know what are the tumors that have this kind of background. They are glycogen-rich tumors. Seminoma, I told you, is one of them. So we performed immunostains, and we got a NOCT4 positive, CD117 positive, and PLA positive. This is a seminoma. CD13 is negative, as it is positive in embryonal carcinomas, and this beta-carotene was negative, and it's general positive not only in oxacs but also in embryonal carcinomas. So this is the picture of seminoma. In this case, you have a beautiful thyroid here. I could not escape and to show you this slide because I think this is a very beautiful slide of a seminoma. CD117 positive, PLA positive. This is the classical picture of seminoma. Now, let's look at another case. This is a 15-year-old male with a mediastinal mass and cervical lymphadenopathy. It's a similar history. However, the slides are different. In this slide, in Giemsa stain, you get some large cells that look like epithelial cells. They can lay single or they lie in aggregates. You notice that they have an eccentric round nuclei with abundant cytoplasm, and some vacuoles are seen here. In a HE, you can remark this. There is a background that looks like mucoid or myxoid background, and you can remark in the cells neoplastic that they have this abundant mucus-like cytoplasm. If you look carefully here, you can notice the presence of this round eosinophilic globule. It's not an erythrocyte. Remark the small erythrocytes you can find here, and this one is quite big. In a higher magnification, you can remark that they exist several of these globules, and they can be intracytoplasmic or extracytoplasmic. And this picture is quite characteristic of a yolk sac tumor. So you can perform immunostains to confirm keratins are positive, PLAP is positive, glypican is also positive. You should also consider immunohistochemistry algorithm that will help you to do differential diagnosis. OCT4 is the first antibody that you can do to divide your germ cell tumors into specific kinds. Those that are positive, like seminoma and embryonal carcinoma, and those that are negative, like in yolk sac and choriocarcinoma and spermatocytic seminoma, but this is the adult tumor. Let's talk a bit about pediatric lymphomas. Pediatric represents the third most common cancer in children under 14 years old. They also represent the second most common cancer in adolescents. And when considering Hodgkin lymphomas, they are fairly balanced. Non-Hodgkin lymphomas are generally adult B-cell lymphomas. However, non-Hodgkin B-cell mature lymphomas are rare in pediatric age, and the vast majority of them are whether Burkitt lymphoma or diffuse large B-cell lymphoma. Small cell lymphomas like lymphocytic lymphoma, follicular lymphoma, mantle cell, marginal zone lymphoma are rare in children. And while in adults, B-cell lymphomas are much more frequent, in children, the proportion of T-cell versus B-cell lymphomas is also quite balanced. More recently, the WHO classification of tumors recognized some rare entities, such as follicular lymphoma pediatric type, nodal and extranodal marginal lymphoma, and large B-cell lymphoma with ERF for rearrangement association. We are not going to talk about these entities because they are quite rare, and there are only few reports on this subject. In children, lymphomas often present as a clinical emergency due to the fact that there is a higher prevalence of high-grade lymphomas with an enhanced threat of tumor lysis syndrome, and due to the involvement of vital structures in the mediastinum and in the abdominal cavity. Lymphomas are fast-growing, and clinical symptoms generally appear very suddenly. Those who appear in the mediastinal area can be associated with airway compressive symptoms, superior vena cava syndrome, or pleural effusions, and those who occur in the abdominal location may present clinical as sudden abdominal pain, vomiting, and they represent in a lot of situations an emergent clinical picture. Here in this slide, you can remark that lymphoblastic lymphoma as well as Burkitt lymphoma are more frequently under 15 years of age. And on the other side, anaplastic large cell lymphoma and also large B-cell lymphomas are more frequently in older children. Diagnosis of lymphoma by fine needle is a challenge. Morphology by itself, it's not enough. You have here a malignant case, probably a Hodgkin lymphoma. You have here a reactive case, probably a mononucleosis infection, and they look very alike. So the lymphoma diagnosis by cytology is mainly based on cell size and morphology and in a lesser extent in pattern, but specific diagnosis requires a multi-parameter approach that includes immunostains, flow cytometry, and molecular techniques. Once again, ROSE permits an excellent sample optimization when done in experienced hands and in order to obtain enough cells. Cell block preparations and cytospins can be done to use with immunostains. It is Important not only to send sample to flow cytometry, but also to spend some in immunostains. Why is that so? Because doing flow cytometry, you will need less quantity than if you wanted to do all these CD markers in immunostains. So with only a few samples, you can have a lot of CDs performed. Also, however, some immunostains cannot be performed or are not performed in flow cytometry routine panels. This is the case of cyclin 1, CD30, and Ki67, P53, and EBER. In the differential diagnosis of lymphomas, sometimes you also need to exclude small round cell tumors. Burkitt lymphoma is an example of this. And the diagnosis between Burkitt, Ewing, and rhabdo is sometimes very difficult, but just by cytological pattern. They both have small round cell tumors, and as I have told you, the three entities have a small rim of cytoplasm with these small vacuoles present in the three. In these two cases of Ewing and rhabdomyosarcoma, they are rich in glycogen. That's why they have a tigroid background in some Giemsa stains. While in Burkitt lymphoma, these small vacuoles have lipids. Genetic abnormalities are also specific in some type of lymphomas and can help you a lot doing and confirming your diagnosis. In addition to the relationship with age, the topography of the lesion is also related to a subtype. Hodgkin lymphoma is generally present whether in the head and neck or in the mediastinum. Burkitt lymphoma is generally associated to abdominal masses or in African countries to head and neck and sometimes central nervous system. Large B-cell lymphoma with ERF4 for rearrangement is generally common in head and neck with involvement of the Waldeyer ring. And anaplastic large cell lymphoma generally is centered in the trunk. Lymphoma accounts for about half of childhood lymphomas, as we have previously said. Most occur in adolescents. Cytomorphologically, there are no difference between the classical Hodgkin lymphoma in an adult or in a children. In the overall pediatric age group, about 90% of Hodgkin lymphoma cases are classical Hodgkin lymphoma, nodular sclerosis. In early pediatric age, mixed cellular subtype has a higher prevalence, especially in children with EBV or HIV infection. And only 5% of Hodgkin lymphomas in children are nodular lymphocyte predominant lymphomas, Hodgkin lymphoma subtype. Hodgkin case. Male, 4 years old, cervical adenomegalies and mediastinal mass. This is a classical history. A background, this looks very much, are you going to see, very much like a seminoma. A background rich in small lymphocytes, some epithelioid cells, they can be together forming small granulomas or they can lay single, and some eosinophiles, again, your epithelioid cells. You can remark and evidence more eosinophiles if you do a Giemsa stain. And in between this background population, you can see large pleomorphic cells, sometimes binucleated with atypical and enlarged eosinophilic and prominent nucleoli, Hodgkin cells or Redstenberg cells. Note that they are CD30 positive. Most of them are also CD15. And they pose sometimes differential diagnosis with other entities that have scattered large cells among small cells. Also, the presence of granulomas in Hodgkin disease should raise you the differential diagnosis with granulomatose reactive process. mononucleosis infection also gives a similar pattern. Anaplastic large cell lymphoma and primary mediastinal B-cell lymphoma also can present with scattered large cells among a reactive lymphoid population. Let's now move to non-Hodgkin lymphomas, and let's start with a relatively common practical situation. This healthy 4-year-old girl. She was pale, sweaty, with a distended and diffusely tender and painful. In a CT, you can see that there is a huge mass, heterogeneous mass that involves all the bowel. The smears were very rich in small to intermediate lymphocytes with a characteristic speckled chromatin and several chromosins. There was apoptosis and macrophages with tingible bodies. This kind of picture can and does frequently occur with a lot of apoptosis. Once again, sustain gives you the presence of these small vacuoles. So small vacuoles you have seen, they can be seen Ewing, rhabdomyosarcoma, and Burkitt lymphoma. Let's do some flow cytometry. It is a lymphoma. It has CD20 and all pan B cell antigens that are positive. It is a mature B cell lymphoma that is CD10 positive, CD38 positive, BCL2 negative, and with a proliferative rate that is more than 90%. This is a classical picture of a Burkitt cell lymphoma. Let's look at this child, 30 years old. This was similar presentation with a large mass involving the abdominal and the bowel. It's a Gim sustain and it looks like the previous one, but you know there are 3 main differential diagnoses where you can see this characteristic. So when this girl entered in the emergency, the hypothesis of a Burkitt after the CT was raised, and so she went performing a bone marrow smear. However, in flow cytometry, there were no CD20 positive cells, and all these lymphoid markers were negative. So this couldn't be a lymphoma. We thought about Burkitt, but this doesn't look like a lymphoma. CD56 is positive. There are a lot, as you have seen, even renal tumors can be CD56, so this is not going to help you much. What are the differential diagnoses? It could be a Ewing, a rhabdomyosarcoma, and considering the age and considering also the location, you had to put in your differential diagnosis a synovial or a desmoplastic small round cell tumor. So other immunostains were performed and other smears were performed. And look at this background. You know it by heart. It is a tigroid background. So Ewing and rhabdomyosarcoma are probably the most probably hypothesis. Immunostains were performed. CD99 was negative. This is not really normal for a Ewing. So myogenin and desmin were positive, and these are very probably a rhabdomyosarcoma. Curiously, in this case, synaptophysin was positive, some cells only, and CD56 was fairly positive and very beautiful. This can happen in rhabdomyosarcomas. CD45 was negative. For sure, this was not a lymphoma. Immunostain was performed, and a fusion with PAX3 gene was seen. So this was diagnosed as a alveolar rhabdomyosarcoma. Finally, lymphoblastic lymphoma. We have seen that they are generally frequent in younger children. They are characterized by these monotonous smears of intermediate to large cells that are uncharacteristic and they look blastic. They have a lot of mitosis. and they are characterized by a CD3 positive in children and markers of immaturity like CD34 and TDT, and sometimes aberrant expressions of B cell markers. Because its location, they sometimes diagnostics are raised in differential diagnosis with thymic hyperplasia and thymoma. Also, the location is the mediastinal in the anterior department. But we know that thymic hyperplasia and thymoma has epithelial cells. Even though you cannot search for them on the microscope, they are very difficult to detect. But if you do epithelial marker by an immunostain, you can find them. And also flow cytometry can help you here a lot, because you know that in these benign situations, there is a normal variable pattern of maturity of your T cell population. And in general, the ratio CD4-CD8 is raised. Instead, in lymphoblastic lymphoma, there is a monotonous and clonal T cell phenotype with a decreased ratio CD4-CD8. Also, you can find aberrant expressions of CDs that are not present in the benign situation, like CD30, CD33, and CD34 co-expressions. Arrived to the end of this presentation. I hope you have survived. I hardly did. But first, let me give you some take-home messages. First of all, we realize now after this presentation how useful fine needle biopsy can be in the diagnosis of pediatric solid tumors and in lymphomas, and that it is capable and it allows us to make an accurate diagnosis in most situations. We have always to have in mind that good judgment must prevail, and we have to know when we should stop, how far should we attempt to go, and we should not push the cytological diagnosis. We realized also that this is a team diagnosis and not a morphologic diagnosis, and clinics, cytology, flow cytometry, genetics, and radiology, they play major roles. Also, curiously, cases that are beyond the diagnosis of cytology can also represent a histological challenge. And once again, ROSE is essential for sample optimization. And if you're able to perform your own biopsies, please do it. You will see how far you can go keeping some material and optimizing your sample. I will be happy to answer all your questions if I know. And so I hope you have enjoyed this presentation and that you have learned. Thank you very much.